In this recorded lecture, we're going to talk about autoimmune diseases. So, for exam number 2, we're going to be talking about rheumatoid arthritis, myasthenia gravis, and lupus. And in this recording, I'm going to talk specifically about lupus. But first, I want to just give you a quick overview of autoimmune disease. So, autoimmune diseases are a condition where the body's immune system, that system that is intended to protect us, mistakes our healthy tissue as foreign and begins to attack us. So, antibodies are produced in response to an antigen, a toxin, or a foreign substance. So most autoimmune diseases cause inflammation that can affect many of our body parts. And what happens is going to be dependent upon what type of autoimmune disease it is. But some of the common signs and symptoms or characteristics that the autoimmune family is seen in autoimmune families is things like fatigue, malaise, fever, muscle aches, joint pain, and joint swelling. And in lupus, we're going to talk about some of the skin problems associated with autoimmune diseases. But you can see that you can also see abdominal pain, digestive disorders, swollen glands, things like that. Now, these symptoms can be mild to severe. And they, as I said, are different based on the type of autoimmune disease that your patient has. Autoimmune is more common in women than it is in men, and we know that there is a genetic link. So, however, we don't really know what the etiology is of autoimmune diseases. There are a lot of theories out there. Some scientists think that it's due to exposure to maybe certain drugs or viruses or bacteria that led to the confusion of the immune system to attack itself. But those theories have not been proven. So we do know that they're generally speaking that autoimmune diseases are seen within a family. So there's some type of genetic link. We know that women are affected 3 times greater than men are. And we know that there are ethnic groups that are more affected than others. So we know that African Americans, Hispanics, and Native Americans have a higher risk of developing an autoimmune disease. So now we're going to talk specifically about lupus. Let me get to that slide. There we are. Okay. So what do you notice on this slide as a distinguishing factor? I would want you to notice that this is what we call the malar rash. And sometimes you'll hear it commonly referred to as the butterfly rash. So this is an autoimmune disease that causes inflammation, and it targets organs, it targets tissues, and it targets joints. That's why I had it on the previous lecture in the arthritis section, because over time it will affect your joints. So this is a chronic disease that has periods of remission and exacerbation. There is no known cure for lupus. All we can try to do is control it. So what's the definition? It's a multi-system inflammatory immune disease that has the potential to affect multiple organs. We know that there is some genetic influence associated with it. The patients are predisposed with an environmental stimulus as well, which is really important for you to know that there are certain things that are going to trigger an exacerbation of lupus. And one of those things is the sun. Also, other things that can create an exacerbation are viruses, bacterias, hormones like estrogen, and certain medications like TB medications, hydralazine, and cigarette smoke is also in that category. So we know that that the body attacks itself, that the immune system recognizes itself as an invader and begins that attack. So what are our goals in caring for these type of patients? We want always, in any kind of patient, we always want to be in a state of homeostasis where everything is in balance. So we want to limit exacerbations. We want to keep that inflammatory process under control, and we want to reduce the overactivity of the immune system. So a patient that has a genetic predisposition for things like lupus, when there's an environmental trigger that leads to cell damage and cell death and exposure of the contents of the cell, such as the nucleus. So what happens here again is we end up with that antibody antigen complex as a result. So these patients also have antigen antibody complexes that can get deposited. So, it's like I told you, lupus it can affect multi-organs. You're going to see this in these type of patients where it can affect their joints and cause some arthritic type issues. It can affect their skin, their kidneys. You'll see a lot of these patients will end up in end-stage renal disease. It can affect their central nervous system. It can affect their hematologic system and their mucous membranes. So let's see what's on the next slide here. So I already told you that lupus is chronic, it's autoimmune, it's progressive, it affects multi-systems, and it can cause failure of major organ systems in the body. It occurs more frequently in women of childbearing age. So there we have that influence of hormone, right? So what happens to hormones when women are pregnant? So the cause is unknown, but there appears to be some kind of a genetic link. So we need to be careful, and we need to be cognizant, I should say, of, especially in women that are having a hormone flux. So we know that, women who have lupus and begin their menstrual cycle may have an exacerbation. They may have an exacerbation during or immediately following pregnancy because there's that flux of hormone. Also during menopause, and also when contraceptions, oral contraceptives are used, because anytime you disrupt that balance of hormone, you can see exacerbation of the disease. And don't forget those environmental factors that I talked about. Sunlight, stress is another one, and chemical exposure. Certain medications also can exacerbate this disease. So again, we have things that are going to be affected. So let's talk a little bit about the clinical presentation. So again, they can have overwhelming fatigue, they can have fever, they can have blood dyscrasias. So what will happen with blood dyscrasias, any one of the 3 cell lines can be involved. So you might see a patient with anemia or leukopenia or thrombocytopenia. So everything along those cell lines will be depressed. So on the skin, I already told you, which this slide is not easy to see, but they can have that malar rash, which is commonly called a butterfly rash. They can also have a discoid rash. They are very photosensitive. Now they can have alopecia, so that is, can be partial or full alopecia. So we would always want to teach them how to care for their skin, how to care for their hair, and it also can affect the mucous membranes of their mouth and of their nose, and it can lead to ulcerations. As far as joints are concerned, you'll have inflammation of 2 or more joints. There'll be stiffness for more than 30 minutes in the morning, kind of the same characteristics that you would see in rheumatoid arthritis. And then they can also have cardiopulmonary involvement, where they're going to have serositis, where you can have inflammation of the outer lining of the heart or the lungs, or any other organ. So this is the group you're going to see things like pericarditis and endocarditis and myocarditis and maybe pleuritis. So all of these things are outlined here for you to see. The renal system is another area of attack. So these patients can have proteinuria, they can have nephritis, they can have glomerular nephritis, they can also present and progress all the way through end-stage renal disease. There can be CNS involvement, central nervous system involvement, where these patients might have seizure activity, they might experience migraine headaches, and they also might have vascular involvement. So what happens within the vascular involvement, you're going to see that when their hands or their feet are exposed to cold, their fingers and their toes may turn white or pale, or they even may be cyanotic, and that is called Raynaud's phenomenon, and that is something that you need to know, okay? And of course, just like any other autoimmune disease, lupus can be mild or it can be severe. So here are some of the diagnostic mnemonics that I have here for you, so that you can actually kind of move through them. And we already talked about serositis, which is cardiopulmonary. We talked about oral mucositis. We talked about arthritis. We talked about how the sun is something that is not a friend of people with SLE. They can have blood dyscrasias, which are going to affect their all 3 cell lines. It can also cause blood clotting issues. They can also have antiphospholipid syndrome, also renal diseases, all the way through stage 5 end-stage renal disease. They usually will have the presence of anti-nuclear antibodies, so that's that ANA that I was talking about. They can also have some immunologic disorders that we test for, which are an anti-DNA and a positive anti-Smith antibody. But I think that's about it. But I do want you to know about Raynaud's syndrome, and I also want you to know about the sun, and I also want you to know about what happens to these patients during changes in their levels of estrogen for women. So when you're diagnosing these patients, you're going to see that they have a positive ANA, which is an anti-nuclear antibody. And so these antibodies are produced against the individual's own DNA. So as the cell breaks down those macrophages, as the cell breaks down, the macrophages aren't cleaning up the debris, so the body stimulates the immune system, and that's where that antibody antigen complexes are formed. So, okay, just so you know, ANA is not a specific test. You'll see an ANA that's drawn in a lot of autoimmune diseases when the workup is happening. So it is not specific. It is sensitive though. So about 95% of patients with lupus will have a positive ANA. Okay, so it's sensitive but not specific. You can also, you'll also see that the patient will have a decrease in C3 and C4 because C3 and C4, they play a role in the inflammatory process, and in lupus they're going to be decreased because they are depleted. These proteins, these will be depleted because of an active immune response. So the proteins are all used up. So you'll see a positive ANA, you'll see a decreased C3 and C4, you'll see an increase in immunoglobulin levels. So usually, and that would be IgM, M for monster. You'll see an increase in CRP and SED rate. And again, those things are suggestive. They're non-specific, but they're suggestive of inflammation, and they're going to be used to assess inflammation. They're going to be used to assess response to medications. They are not diagnostic. Okay. You'll see a positive anti-Smith antibody. You'll see an increase in anti-double-stranded DNA, and you'll see a positive anti-phospholipid. So these are antibodies that develop that are directed at the phospholipids, and if you kind of remember, the phospholipids are they're the fat-like phosphorus containing substance, and they're really important. They play a big role in the actual metabolic process that happens within living cells. So in the SLE patient, you'll see that this is positive in about 30% of patients. And of course, you're going to do a CBC, you're going to do a CMP as well. But here, really important to understand what's going to be positive, what's going to be increased, what's going to be decreased, and what's going to be positive. So how are we going to treat these patients? What are we going to do for them? So they have, their symptoms that they present with sometimes are arthritis-like. They may have some arthralgias, and those arthralgias or joint pain are going to improve with the non-inflammatory the non-steroidal anti-inflammatory drugs. So remember that the NSAIDs, they decrease inflammation, they decrease pain, but remember that they have side effects. They can have GI side effects, and they can lead to gastritis. It can lead to a GI bleed, for example, and also sometimes there's renal involvement as well. So we have to be careful with the chronic use of NSAIDs. So some of the NSAIDs that you already know about are ibuprofen, naproxen, Celebrex, Toradol, and aspirin. So hydroxychloroquine, we should all know about hydroxychloroquine as we have gone through COVID, all right? So we use hydroxychloroquine, and that was one of the big things during COVID. People were worried about individuals that do have these chronic diseases, that hydroxychloroquine would not be available for these individuals because they help to decrease inflammation when the patient has flare-ups, and they're known to decrease mortality rates as well. So hydroxychloroquine is an anti-malarial. It's used to treat things like fatigue, joint and skin problems. The individual will take between 400 and 800 milligrams twice a day, and it can be taken for several weeks or months. So the maintenance dose, once they are under control, is about 200 to 400 milligrams twice a day, or once for the total dose for the day, I should say. So sometimes we know hydroxychloroquine as Plaquenil. So we can also use Dapsone, which is an anti-leprosy drug, and Dapsone is used when a patient cannot tolerate hydroxychloroquine. And then, of course, our favorite drugs, the corticosteroids, which we know decrease inflammation, but we want to use them on the short term because when we use them, we're going to further suppress that immune system. So we have things in that category like prednisone, methylprednisolone, hydroxycortisone. So we want to use them in limitation. So we can give methylprednisolone IV with tapering doses when our patients have a flare-up of their lupus and specifically polyarthritis. But one of the things that we need to also be worried about with corticosteroids is how it affects blood glucose levels. So we know that steroids increase blood sugar. Also, chronic use of steroids can affect bone health. So it can decrease there will be bone loss, bone mineral loss, and so that will lead to osteoporosis. And when a patient has osteoporosis, that can lead to bone fractures. So don't forget about the side effects of these steroids. We can also use cyclophosphamide, which is a chemotherapeutic agent, which is immunosuppressive, and it's usually used to treat severe organ involvement in lupus. So we know that there can be, like I said before, kidney involvement, and you'll see that these individuals will receive cyclophosphamide. And one of the nice things about cyclophosphamide is that it can reduce or prevent the long-term use of corticosteroids. Warfarin can also be used when we have an increased propensity to clot. So as you know, already know that warfarin is a anticoagulant, and we're going to monitor our PT-INR to make sure that our patient is within the acceptable range. They're not too thick, they're not too thin, if you will. So know that it is a blood thinner. Tacrolimus is another drug that is often used for patients. It's a topical product. It's a topical immune modulator that suppresses the immune response in the skin. So you're going to see patients who have those skin rashes using tacrolimus instead of the things that we usually give patients, which are topical steroids. And belimumab is an immune modulator, and remember that it can reduce the response of the immune system. And one thing about it is that you want to tell your patient that they may not have any live vaccines when they are receiving this immune modulator. Some of the side effects associated with it are depression and suicidal ideation. So that is something that you need to be cognizant of. And I've already talked to you about methotrexate, and nothing changes there with methotrexate. Okay. All right. So what is our focus here? What's our nursing focus when we're talking about lupus? Of course, there's going to be periods of remission mixed with flares or exacerbations. So we want to educate our patient on things to prevent or avoid sunlight, for example. Protect your skin with at least 30 SPF and reapply it as necessary. Avoid being around people that have a known infection. Try to reduce your stress as much as possible. And surgery and pregnancy. Surgery is a stressor, of course, and pregnancy, we know, changes the flux of hormone, specifically estrogen, and so surgery and pregnancy can lead to flare-ups, and postpartum can also lead to flare-ups. So we want them to have skin protection from UVA and UVB light as well as sunlight. Of course, we're going to control their pain. If they do have pain, we're going to use, as we said before, some NSAIDs and some other medications. If we have exacerbation, when they're having an acute response, we can also do something called plasmapheresis, where the patient, the plasma is filtered through a big machine, and those antibody antigen complexes are filtered out, so they're removed. And of course, a patient is usually hospitalized when that happens, and usually they'll get a boost of immunoglobulins IV, so they'll get IVIG following plasmapheresis. So you need to know what plasmapheresis is and what are the possible side effects of plasmapheresis. So, of course, our goals are always to educate and to teach patients about what are the risk factors and how to keep them, reduce their risk for a flare, and how to support them, because they are going to have some changes to their physical appearance, which, as we know, can lead to self-image disturbances. And then, of course, the medications that we're going to use to treat them, which can put them even at higher risk. Some of these medications can put them at higher risk for infection. And we know that when the immune system is modulated or it's suppressed, and you add other factors such as increase in age, sometimes, patients can really deteriorate. They can end up in septic shock, for example, because, the signs and their body doesn't respond like somebody who has an intact immune response. And if we're not hyper vigilant about the signs and symptoms of infection, they can go undetected, undiagnosed, and your patient will go down that rabbit hole of shock. So be very careful when you have these patients that are chronic, these patients that are on steroids all the time, and they're getting additional immune modulators because they're having an exacerbation. So I think that, what are the potential nursing diagnoses? I think that we probably could do that pretty easily. We already said disturbed body image. Of course, they're going to have disturbed skin and tissue integrity, especially, if they have a discoid or that malar rash. And of course, they're going to experience fatigue. So that will end what the recording on lupus.